Hello friends, welcome to Cortex YouTube channel. In this video, let me begin this topic with a question, clinical question. Here is a young male with new onset seizures, no comorbidities, there are no addictions, and no family history of seizures. So MRI flare sequence is given in this image. So what's your diagnosis? Pause the video. If you know the answer, please comment your answer in the comment section. And we'll come to this question later. Let's begin our topic. So today's topic that I am going to talk about is NCC, that is your neurocysticercosis. What is this? It is most common parasitic. It is a most common parasitic disease or infection of CNS worldwide. Okay, worldwide it is the most common parasitic infection. Later comes your toxoplasmosis and other parasitic infections. So remember, it is parasitic disease, most common disease. So what is the cause? If you look at the etiology of this NCC, people will acquire NCC or they get NCC by ingestion of contaminated food. See, I'm not writing here any pork or something or non-veg. I'm just saying it is contaminated food because even vegetarians can get this NCC. Okay, contaminated food. In fact, it is seen more commonly in vegetarians than in non-vegetarians. So cause is ingestion of contaminated food, food contaminated with the eggs of parasite. What is that parasite? Taenia solium. So let me drag that Taenia solium for you. Yes, this is Taenia solium. Okay, this has a head part, tail part. Okay, so many proglottids. So head part has rostrum hooks by which it attaches to the intestines and it suckers, and the head is the neck part and immature proglottids. So this whole part is called as scolex. Scolex constitutes rostrum hooks and suckers. Okay, so this why I am telling this scolex, because it can be identified on MRI in vesicular stage, initial stages. Oh, don't worry. So this is the worm or parasite. What is the egg or cyst form? Exactly. This is the microscopic picture of egg of this Taenia solium. Ingestion of the food contaminated with this egg. Okay, this is egg of Taenia solium. If we ingest any food contaminated with this egg, we may get NCC. Okay, especially this infected cabbages and all. So that's why if you bring any vegetables to home, you have to wash them thoroughly. Okay, so that is the regarding etiology. So what is the clinical feature? How does patient presents to us? That is very important for us. So this class is going to be very brief and not in detail. I am not going to discuss about life cycle of the parasite and all, because it is not the scope of this video. Okay, now let us discuss about clinical features. So what are the clinical features? How does it present? It depends upon the location. So depends on location. Depends on location of the cyst circi. So if it is present in the brain parenchyma, as I showed in the question at MRI, that was there in the brain parenchyma, so it presents as new onset seizures. Patient had never had a seizures in his life, but he developed one episode of seizures. So that is first or new onset seizures. So patients will present like that. So in childhood or in till the age, till that episode, he will not be having any history of seizures, and family history, hopefully family history will be negative, but he developed seizures. So new onset seizures, usually it will be focal seizures with secondary generalization or sometimes GTCS. Okay, next, sometimes what happens, it may present as focal neurological deficits. Okay, this is when it is present in the brain parenchyma. Sometimes these cysticerci can be present in the subarachnoid space or ventricular space, so it can present as raised ICP. It will increase the intracranial pressure. Now it sometimes cysticerca can be located in the spine. So spinal cysticerca, spinal NCC presents with, it mimics like spinal tumor. Okay, so this is clinical feature. So usually it will be present as new onset seizures. Today only I have seen one case, classical history. Young male presented with the new onset seizures. It is GTCS. His wife was accompanying him, and MRI showed colloidal stage of NCC, and we prescribed him albendazole, and after ruling out ocular NCC. Okay, so this is regarding clinical features. What is the diagnosis? How to diagnose? Well, the initial investigation that we do is MRI or CT depending upon the stage. So we go with MRI, and the confirmatory test that is recommended if necessary is enzyme linked immunotransfer blot. We don't do it routinely, but what we do routinely is MRI. Okay, so MRI, it will tell about the stages of the neurocysticercosis. There are so many stages like vesicular stage and colloidal stage, and okay, I'll write here first: colloidal stage, colloidal, and granulonodular. Fourth one is calcified, chronic calcified stage. Okay, vesicular, colloidal, granulonodular. Why it is very important to know about the stages? Because see, calcified, it's chronic dead tissue, you need not treat it. So vesicular stage and colloidal stage are viable parasites, so obviously they need treatment. And granulonodular, it is plus or minus. Some people will recommend, some people won't recommend. Okay, and if resolution of these stages is seen on MRI or CT, we can plan in stopping the antiepileptic therapy. Okay, that is one criteria. So let's begin with this vesicular stage one by one. So I will show the images also simultaneously. So let's talk about vesicular stage. Vesicular stage is characterized by, okay, let me explain it the diagram itself. So vesicular stage. Okay, this is a MRI film. Okay, first let me write here, this is MRI film. Which sequence? It is T1 and post contrast. See that contrast is visible. Post contrast T1 MRI, which shows, so this is your right side, this is your left side. It is universal. So right, see, this is frontal lobe, this is occipital, and this is your parietal lobe. See, in parietal lobe you are getting a cystic lesion. Okay, cystic lesion in parietal lobe. Okay, there is cystic lesion in right parietal lobe. With, look at this carefully. There are this hypointense, I will erase here, there are here hypointense spots. They are called as your scolex. So with lobe with small hypointense spots, they are called as your scolex. Scolex means it is viable or living larva. Okay, so definitely it needs treatment. So vesicular stage is characterized by cystic lesions with small nodules called as scolex, and there will be no significant edema. So here also in this picture it is not showing any edema. Let me take you through the T2 weighted vesicular stage only, T2 weighted MRI to look for edema. See, this is T2 weighted MRI. See, this is also MRI. CSF shows, CSF is white, T2 it is white. So MRI, this is MRI film, T2 weighted. Okay, So look at the same lesion. Look at the same lesion in the T2 weighted in the right parietal lesion. What happened here? It became hyper intense. So hyper intense lesion with small hypointense nodules. Look at this carefully. There are two dots here which are black. That is hypointense. So hypointense areas. Two hypointense areas. They are scolex. Hypointense nodules. They are again telling that it is a scolex. So it is vesicular stage. Scolex is present. Definitely it needs treatment. Let me talk about now colloidal stage. Hope you understood the vesicular stage. Colloidal stage. Remember, there is cystic lesion with scolex with no significant edema. Okay, colloidal stage. How it is characterized? So colloidal stage is okay. Let me show you an example here. Okay. This is MRI film. Which sequence? This is MRI film. Which sequence? Comment below. Look at here. What happened? This. Okay. Let me comment here. This is MRI sequence. Obviously, this is right side. This is left side. MRI. Here, where is the lesion? First, see, this is frontal lobe. This is parietal. This is occipital lobe. So it is lateral part. This is medial part. So medial part of the occipital lobe. There is obviously cystic lesion is there. No doubt there is cystic lesion. Cystic lesion. Where is the location? In. Is it on the right or left? Occipital or frontal? Occipital. Which part of the occipital? Medial part of the. So medial occipital lobe. Okay, what happened? This is a contrast. Look at this. There is contrast here. So post contrast enhancement is seen. See, ring is there is, see this enhancement. This is called as enhancement. What it is? Post contrast enhancement. Okay, if you see the same thing on the flare sequence of the MRI, there is significant edema. Look at here. Look at the same lesion on flare sequence. Flare is nothing but your fluid attenuated fluid. Flare sequence is what? Fluid attenuated inversion recovery. Okay, this is MRI flare. Sorry. Flare sequence. Okay, what happened here? Same lesion. Here there is significant edema. Flare is showing significant edema. How to describe that lesion? There is a cystic lesion with surrounding significant substantial surrounding hyper intense. Okay, in MRI anything is white is hyper intense, anything black dark is hypo intense. So this is hyper intense lesion sizes of edema, surrounding edema, significant edema is there. So colloidal stage, you have to have edema. To call it as colloidal stage, you have to have edema. Okay, so obviously it needs. What is that edema? Edema significance host immune response. There is a lot of inflammation is going on. So this patient's presents usually with the seizures because of local irritation by that inflammatory response. Okay, now let me talk about granulonodular stage. Third stage, granulonodular stage. By this stage, what is happening is host is trying to contain that infection. Okay, by mounting a strong immune response, and the surrounding edema would have reduced now, and the scolex or the cyst is degenerating and almost degenerated. Okay, let me show an image here. Okay, these two are okay, this is an example of granulonodular stage. Granulonodular stage. This is post contrast T1 image. because you are seeing contrast here. So this is T1 post contrast. Because small is uniform or enlargement is the enhancement is there. Okay, enhancing lesion in the, where is the lesion? Look at this. Okay, this is, got it. Okay, it is in the putamen and it is in the internal capsules in the medial part. So okay, where is the lesion? In the left side. Okay, this is left side, this is right side. So left putamen and internal capsule. Okay, this is the site of the lesion. Look, so there is no edema, no edema. This granular nodular stage is characterized by no edema. Edema is absent. If you are finding edema, it is not granular nodular. It is if you are finding significant edema, it is colloidal. If no significant little edema, it is vesicular stage. One more picture of the granular nodular I will show here. So this is the same site, same infection. Okay. Now let me talk about calcified, chronic calcific stage. So I'll show you an example. See, calcification. Calcification is best identified on CT scan. So calcification is best identified on CT scan. Sorry for disturbance. Yeah, I have put the phone in silent mode. Okay, so chronic calcified stage. Calcification best seen on CT scan. So we order CT here. So what happened here? In fact, it is one of the most common cause of intracranial calcification, especially intraparenchymal calcification. Look at this, how many calcifications are there? See, this is how to identify it is bright spot is calcification only. So you have to compare that density with this skull density. It will be same. Okay, look at this density and this density same. So this is case of calcified NCC. Okay, does it require treatment? No. Okay, so this is about the stages that you see in the diagnosis of the NCC. So the confirmatory test, yeah, I will write here confirmatory test. Confirmatory test, if needed, what we have to say is it is enzyme linked immunotransfer blot. Okay, this is the confirmation test, but we don't do it routinely for every patient. Okay, yeah. And before starting treatment, whenever you suspect NCC, you have to do fundoscopic examination for all the patients. So fundoscopic examination to rule out ocular NCC is must for all patients with suspected NCC. When you suspect NCC, you have to have fundoscopic examination, ophthalmological consultation you have to take. Next, yeah, treatment. Coming to treatment part, I think so far so good. You have understood whatever I had talked about. Treatment is very simple. See, parasite is there, we have to kill that parasite. When we have to kill? When it is causing problem. So when it is causing problem, when it is alive. When it is dead, calcified, it doesn't create much problem, so you need not treat it. So when it is viable, so how to define viable parasite, viable lesions? So any lesion which is cystic in nature and which has colex and perilesional edema is considered as viable, and it is usually seen in vesicular and colloidal stage. So whenever you are finding vesicular and colloidal stage, so you have to give cysticidal treatment. So cystic lesions in the brain parenchyma with or without pericystic edema. So pericystic edema is not necessary. So it has to be cystic lesion. Cystic lesion in the brain parenchyma with or without pericystic edema, or in the subarachnoid space at the convexity of the cerebral hemisphere needs cysticidal treatment. So whenever patient presents with seizures, when seizures are present, whenever patient presents with seizures, you have to treat him with anticonvulsant medications, anti-epileptic treatment, anticonvulsant therapy. Okay, you started him on anticonvulsant therapy, one of the anti-epileptic, let's say levetiracetam, depending on the weight. Now you have to give cysticidal therapy also. I will tell when to stop this anticonvulsant therapy later. Cysticidal therapy. So cysticidal therapy depends upon the number of lesions. If the lesions are less than 2 and if the lesions are more than or equal to 2, what's your approach? So when cysticidal agents that we use are albendazole and praziquantel. So whenever the lesions are less than 2 viable lesions, whenever I talk about lesions means viable lesions, when they are less than 2 viable lesions, right here for your sake, less than 2 viable lesions, you give albendazole alone, monotherapy albendazole. How much to give? 15 mg per kg per day. Okay, 15 mg per kg per day. If the patient is 10 kg, you give 150 mg. Is it given in single dose? No, it is given in 2 divided doses. In 2 divided doses. Okay, understood this much. Now there is one trick here, I will tell you later. What if the lesions are more than or equal to 2? Now what we have to do, we have to add this albendazole plus praziquantel. Okay, praziquantel. So what is the dose of praziquantel? So albendazole remains same, 15 mg per kg per day in 2 divided doses. For how long? Yeah, I will tell here. So praziquantel is 50 mg. Remember, it is 50 mg per kg per day. Okay, again it's given for how long? You have to give for 10 to 14 days. That is what is recommended in Harrison. That is what is mentioned in Harrison 21st edition. Now the trick here is that I told previously, there is a trick here. So albendazole you cannot start immediately. So first what you have to do is you have to cover the albendazole or cysticidal agents under steroids. So you have to start steroids first. First is steroids before cysticidal therapy. So steroids, what steroids you can use? You can use prednisolone or dexamethasone. So you start prednisolone, okay, and after 3 days you give cysticidal agent. Today I told you, today I have met a patient with NCC. We started him on albendazole. So we gave prednisolone 40 mg OD. After 3 days we asked him to take albendazole tablets. Okay, because when you start cysticidal therapy, the larva that is there, it will start degenerating or it start dying, because dying parasite will result in a massive inflammatory response. So to curtail that inflammatory response, we give steroids, because inflammatory response in a brain is very, very dangerous, because it may result in seizures, raised ICP, even death also. So we don't want that complication. So we give steroids first, after that cysticidal therapy. Now so far so good, I think. Hope you understood so far. Now I told before that when to stop anticonvulsant therapy. Does he has to take lifelong? Well, answer is yes or no, depending upon the situation. So let's consider the situation. So antiepileptic drugs, when to stop? You can stop in some conditions, but in some patients needs it long term. So when to stop? When to stop is whenever you get a follow-up MRI or CT showing resolutions of the lesions are resolved or resorpted, or there is calcified stage, so you can stop that. Or when the patient is seizure free for 24 months, that is 2 years. When patient is seizure free and CT MRI showing resolution of the lesions, you can discontinue or stop the medication, or sometimes continue when to continue. But when seizures occurs, even after resolution, seizures occur after resolution. See, you have seen resolution, but seizure has happened again, and there is no other attributable cause. You have to start anticonvulsant. I mean, you have to continue the anticonvulsant therapy that you have started. Okay, resolution are even in calcified stage. Okay, long-term anti-epileptic therapy is recommended. So this is regarding neurocysticercosis. Hope you understood this topic. Hope you find this video informative. If so, please like, share and subscribe, and share this among your friends, colleagues, juniors. Okay, uh, if any doubts, you are free to ask in comment section. I'll be happy to answer those queries. Okay, yeah, coming to this question again, is where now it becomes easy. Okay, young male with new onset seizures, no comorbidities, no addictions, no family history, no previous episodes of seizures. What's your diagnosis? Flare image is showing colloidal stage because there is significant edema, cystic lesion with significant edema and hypointense lesion in the cyst. That is colloidal stage, so you have to start treatment. Here it is, the diagnosis here is NCC. Okay. Yeah, please comment your feedback in the comment section. Thank you. Thank you for patient listening.